Great, thank you for having us. So we'll go and start briefly with some introductions and who we are. And our topic today is going to be really around the basic building blocks that must be in place for any center's success. So I'll start with myself. My name is Jamila Hokanson. In addition to doing psychedelic research at Yale, both with psilocybin and MDMA, as well as soon-to-be young adults, I also have experience with owning and operating a group private practice, mainly around ketamine. And I'll go ahead and let Greg introduce himself, and then Brooke.
Thank you. Good afternoon, everyone. So I'm Greg Kearns, currently serving as the Interim Executive Director and Chair of the Board for the Alchemy Community Therapy Center, which is a sliding scale clinic in Oakland, California that is offering services to BIPOC and queer populations. And we are also operating a training program, and I'm really pleased to be with you today.
Hey, everybody. Nice to see some fresh faces out there. I'm Brooke. I have had a relationship with psychedelics for 36 years, and I've had a relationship with mental health as a consumer for 38 years. I've been a psychotherapist and researcher for nearly 20 years in Los Angeles, California, and in the last 6 years, I co-founded and own a psychedelic therapy center in central Los Angeles called the California Center for Psychedelic Therapy. And we're going to talk a bit about how that's been.
Great. And we'll start with you, Brooke. Actually, can you talk a little bit more about what specific services you offer, sort of what your tax structure and legal structures are?
Sure. So in California, there are some extra bureaucratic layers of how you can organize medical corporations. And so the center is a medical corporation. It's co-owned by I'm one co-owner, and then my partner is a psychiatrist. He's the other co-owner. My business partner, not my life partner, just to clarify. Although it feels like a different kind of life partnership when you own a business with someone, that's for sure. And so he, as the medical provider, he has to own 51% of a medical corporation in California. I own the other 49%. We have equal votes on our board. So we actually make decisions in a parallel, lateral way, but he does own 2% more of the business because he has to in order for it to be a medical corporation in California. We provide ketamine-assisted psychotherapy, good old psychotherapy, psychedelic integration, medical management through that company. And then we have a branch that's an LLC that's a research company. And so our medical corporation hosts research projects. Another intricacy of California medical provision is that you can't provide research through your clinical provision company. They have to be separate entities. So we have the LLC, which is where we do our research, and then we basically lease our space from the center to ourselves and run the research. So you can already hear that there's a lot of back-end business that you have to learn in order to have an above-board medical psychedelic research clinical center. I'm a therapist, so this has been a language that I've learned, and I think we'll talk a bit more about that, but that's how ours is set up.
Okay, Greg?
Yeah, so Alchemy actually operates as a 501c3 nonprofit, and we are also in California, which, as Brooke alluded to, is a complex state to be operating in. There is, like many other states across the United States, actually a corporate practice of medicine law that does not allow 501c3s to actually employ medical doctors, and we cannot actually prescribe or work with medicine. So we actually have to operate with a collaborative agreement with a separate institution or organization that is working with us to do the prescribing. So we have a collaborative agreement, and our organization only is employing the therapists that are providing our services. So we're offering ketamine-assisted psychotherapy and traditional psychotherapy. Last year we served about 350 clients, did about 6,600 therapy sessions and about 200 CAP sessions. And in addition to the therapy that we are offering, we are also offering, as I mentioned, training, and we're doing that in 2 formats. So we're actually offering a 2-year associate training, and that's for folks that have finished their schooling but have not yet become licensed. So they're working with us in gaining their hours towards licensure over the course of a 2-year period, where we're also training them in how to offer ketamine-assisted therapy. And then we also have a 7-week public training program. Plug, we are currently openly enrolling for our next cohort, and that is a 7-week program that is open to licensed practitioners that want to learn how to provide ketamine-assisted therapy in our model.
Okay, great. So we see here two different models. One is an LLC, kind of for-profit. One is a nonprofit. Given those different kind of legal and tax structures, let's turn our attention to, I'm curious about what are the respective governance as well as decision-making that had to happen and lessons learned in regards to access to funding and capital. Greg, we'll start with you.
Sure. So as a 501c3, we obviously have a board of directors operating at that level. In my training, I'm a healthcare strategist. I've worked mostly on the business side of healthcare my whole career. I've really been trained that there's a real distinction between governance and management. And so from a governance perspective, where I'm also sitting on the board level of this organization, we're really held responsible on the fiduciary responsibility side and then really holding the responsibility for ensuring the quality and safety of the care that we're providing. But it's really the management team that is executing on all of this, right? So the board, I think, has been really maintaining that relationship with management to make sure that we've got a really solid check on what the budget looks like, supporting them in the fundraising process, and then having routine check-ins in terms of what quality, safety, how the program is actually running. But on the management side, as I've stepped in now on the management side, I've had a much deeper look under the hood and been much more involved in the operation. And I see my job really within that operation as truly empowering the practitioners. And so putting the providers at the center of everything that we're doing and learning from them, hearing from them, what does it actually need to look like to run this business? And then doing a lot of listening to then dissect that and figure out how do I translate that into the business side of this? How do I build budgets and all of that? So that's kind of how we're distinguishing between our board level and our management level.
And so for me, I'm both the CEO and the clinical director. And my business partner is the president and the medical director. And the way that we built our business was grassroots. We don't have any funders. We make the money that we pay ourselves and the rest of our team. So our work with our patients directly pays our bills, both in the center and in our lives. And partly why I wanted it that way was because there were no business people that were interested in doing a psychedelic clinic 6 years ago. And so this room wouldn't have been full of people that were just dying to fund things. Even academic centers weren't doing much at that time. And so that kind of seemed like the way we could do it. I had already been a clinician a long time. He had already been a psychiatrist a long time. And we were lucky enough to have sort of a team of other clinicians and doctors who just had a dream of bringing these treatments to our community. And so that's been really lovely in that sense that we answer to us, we answer to our patients first and foremost, and so what they want is what we try to give them within the bounds of the regular frame of therapy and medical provision, of course, but that's given us a lot of freedom with creative treatment planning, with relationship, with building a lifestyle for us as employees of ourselves that's healthy for us so we can be in healthy relationship with each other and with our patients. The downside is that it's been a real crash course, I think, for all of us involved at my center in learning how to speak the language of business. And so there's the practical piece about, like, how do you sleep when you have 12 hours of patients and then you have 12 hours of business work to do. But I think it's been worth it for us because we have full liberty. And I came out of working in public health and community health hospital systems in my same community and saw a lot of waste, saw a lot of bloat in the way that things were run, and I saw how far that could get from the patient's needs. And so it was really important to me to center that at the beginning. And so I see the model that we do sort of with the patient in the middle and the providers around it, and then the business is kind of the container that holds it all, not the other way around. And I think there's been a lot of pros for that, especially when it comes to service provision. I think some of the cons have been that there are a lot of people that are wonderful providers in our community that don't want to work like that or can't work like that for other reasons, sort of like the, almost like an assembly line, right? Like as many pieces as you put together is where the money is left, and that builds out the programming. And so I think that now that we're in a moment where we can collaborate more with people, kind of like you're talking about, not having to do it all as anybody. Any role in the organization should not have to do it all is something that I've learned along the way. And so even though at my center we have it structured so that it's not about Brooke, it's about having a clinical director and knowing what the clinical director does and knowing what a CEO does and having those roles really clearly defined so that if any of us change our mind or something happens to us, the business can survive. But also starting to find out that what are the ways that we can work together to try and keep that central service provision, the providers and the patient's needs at the center while not having to hold it all itself, I think is something that, looking back, I maybe would have wanted to be different. Or if I was doing it again, I would do it a little bit differently by sort of cross-pollinating across from the business world and the clinical world in a different way.
And Brooke, can you share a little bit about the approximate startup costs for your clinic and then where that initial capital investment came from?
Yeah. So what my partner and I talk about is, it's all the same as it's always been. You just put 1 or 2 extra zeros at the end. And so we signed the lease on our office that we're in now, which was our second site. It was a growth moment for us in late 2018. And it cost $35,000 to sign the lease, which was the biggest check I'd ever written for anything. I have student loans. I'm a former teen mother. I don't come from wealth, neither does he. And which is kind of where that grassroots ethic, I think, came from. We didn't trust people who had money. And so that's how we started it. And then we hung a shingle on the door, and we tried to create a model for cost in our community that is really about the time that the psychiatrist or the medical provider, we now have RNs, psych nurse practitioners, and a psychiatrist on our medical team, and we have LCSWs, MFTs, and psychologists on our clinical team. And we work together in a co-therapy model. And so the cost that we charge to our clients is the going rate for the time that those 2 providers pay if they were going to see a psychiatrist and a therapist elsewhere. And so that is sort of how we built out that financial structure. I thought it would take 3 years. I said if I can't get that $35,000 back, which is still a lot of money to me, but was even more than, in 3 years, I'm going to bow out. Well, I'll give myself 3 years to pay ourselves back our loan, and we were able to pay it back in 6 months, just by working for ourselves. And so, yeah, so it worked. It's worked.
Great.
The overhead now, 6 years later, the overhead monthly expenses are about $60,000 a month.
And speaking of the overhead, that's a good segue. Can we talk about the day-to-day operations and sort of what models did you guys consider and how does it look like in your organization? Greg?
Sure. So we were really fortunate that a couple of our original founders had already started up a clinic in Berkeley area called Sage Integrative Health, and so they were really instrumental in providing a lot of the underlying kind of operational components, policy and procedure manuals, and things that they'd been thinking through in terms of clinical workflows and all of that. So that was really helpful in terms of standing us up. In addition to some very generous support from other clinics that were already operating in the space, including a clinic called Healing Realms in the Bay Area. With regard to the day-to-day operations, I think there's just things that have to be in place to open the doors, right? You've got to make sure you've got your malpractice insurance. You've got to be able to run your payroll. You have to be able to handle HR issues. You need an electronic medical record system. These are not things that you need to reinvent the wheel. There are vendors out there that you can go and bring in, and you just have to be orderly about them and organize them. And so I've been operating in the space for the past 5 years, also providing consulting through my consulting entity, and this concept of playbooks has been emerging. And so since stepping in on the operations side of Alchemy in October, I've been working with the team to say, all right, you guys had all these things in place, but we haven't necessarily done the greatest job of systematizing them. So we're actually in the process right now of really making sure everything is systematized, and we're really, really clear about, like, this is how all these things operate, so that from 1 year to the next, as we find ourselves needing to do routine things like our audit or like a workers' comp audit or things like that, we don't have to reinvent the wheel every time. It becomes a much smoother operation.
So for me, I think it was a little bit maybe backwards. Prior to opening the center, I had worked for about a decade doing therapy and developing, implementing programs in other centers and other systems of care, county-funded, public-funded systems across LA. And so I had a lot of skills personally to already know, like, what are the, like, what's an employee manual, and what are labor laws, and like, how do you, have like the HR pieces and the EHR and all of the things that you need. I knew all that because that had been my job in other settings for 10 years. The biggest challenge for me was tech. Tech changed a lot. I'm just right at that age. I'm, right at that age where like I had it all down in my like Word documents. And and then it was actually through my peers, so Sage, Polaris, a couple other places that were doing sort of similar things in California that, I'd kind of be like, are you guys like having people write you notes when they want to take PTO and then like logging it on your spreadsheet? And they're like, no, there's a thing called Gusto, and it's like an online HR program. And so for me, it was more of like transferring those skills from sort of a very old-fashioned, like clinical direction job into the modern world where there's this more sort of portability and tech involved, and learning all those new programs. And we have an administrative director as well who has a prior career doing billing and insurance claims and operational stuff. And so she and I work together a lot to sort of learn that, figure it all out, and implement it in a way that feels like modern, but calls on that sort of tradition. And so when things come up, like something came up once with a labor law thing, and an employee was concerned about this, and it was really nice for me to be able to go like, oh no, I know that, but I know that law because I had all of that experience before. That's not what I'm learning. What I'm learning more is like how we implement that in the modern world where people are younger than me for the most part at this point.
Now, the other thing we want to now pivot on to is looking at sort of the three-pronged trifecta of quality, safety, cost, and access. So let's talk about quality and safety first. So in regards to that, what structures or processes have you put in place to kind of monitor and make sure that you're having quality services as well as safety for your clients? Brooke, why don't I have you start first?
Sure. So we're very traditional in the way that the services are provided. We follow all, there's a large pie of humans and psychedelics, a big circle of all the ways that humans and psychedelics interact. And, at my center, we're a very small sliver of that. We're a medicalized therapeutic provider of these medicines to treat mental health. And so we rely on the existing systems of care in mental health and medicine. We have ethics boards that we comply with. We keep up with our CEUs. We listen and consult with our malpractice all of the time. So that's very traditional, even though the services that we're providing might be a little more innovative. And then we have regular weekly group consultation. Everybody on our team has one-to-one consultation all the way up to the owners. And so we do community around the work that's happening. We even have something that we call a collaborative care model, where sometimes our clients move between us and we hold them collectively. And so we do a lot of collaborative work, which I think, especially with the amplified vulnerability that patients have when they're in the room with someone who's not using psychedelics and that they likely don't know very well, because we are traditional medical providers. We're not like sharing a lot about ourselves all the time unless it seems clinically appropriate to really protect their safety and our safety by working together collectively in that way. And then we use a very traditional medical record system too, and so we keep notes just like any other doctor or therapist would keep notes. We do consents just like any other doctor or therapist would do consents. And we have part of my job as the clinical director is to do like a QA audit of the documentation, tracking who's coming. Our EHR sends out surveys to our patients so they can identify anonymously what they liked and didn't like about services that they received, and we look at them and we talk about them and we adjust accordingly.
Greg?
We have a number of similar systems in place. So we're really fortunate that we've got a very strong quality assurance program in place with a dedicated quality assurance manager who has put together a really awesome internal tracking system to really make sure that our folks are staying on top of documentation, really being clear about what work we're actually doing that's really important right now because we have to acknowledge that we're actually working with medicines that are being prescribed off-label. And there's, to be honest, a degree of like CYA that needs to be happening here. And so documentation, if we were ever to be audited as it relates to the work that we're doing, is so critically important. And so given that we're a training organization and a lot of folks working with us are still very early in their careers, it's really important for us to be getting folks in this habit of strong documentation from the very beginning. And so we're really intentional about that. As it relates to tracking metrics and outcomes, we too are soliciting feedback from our clients. We've got a client experience survey that we have developed on our own where we're asking questions around how they would rate their service, how they would rate their relationship with their provider. Do they feel like they're actually making progress as it relates to the issues that they've come in to work with us on? How culturally appropriate and relevant do they feel like the services that we're providing are offering? And then really receiving that data back and then discussing that as a management team to figure out how do we need to be implementing changes or changing some of the things that we're doing, training providers to offer things in different ways. Using that continuous quality improvement kind of feedback loop is critically important for us because, and I think we both share this philosophy, the quality and the safety of the service that we provide, that is our product. And that is what is going to drive our business. It's really going to be what drives the word of mouth referrals. If you have clients that are really pleased with the work that you're offering, they're going to tell others and they're going to be sending folks your way. So that's how we're really thinking about the commitment to quality and safety.
I think one other thing that comes up for me as I was listening to you, Greg, also is that science is a real thing. It doesn't cover sort of the wholeness of the way that we can know whether something's quality or safe or not. But I think in the medical setting in particular, in regards to the off-label use of ketamine, we really, and our prescribers in particular, really rely on evidence. And so we really look into the research, what's published, what is the standard of practice that peer-reviewed research has showed would be a safe way to use or provide. And so we hold that amongst ourselves, but then we also inform our clients that that's how we're working, and so that they can have a choice if that's how they want to work. And we do have people that don't want to. They want to be more collaborative. They want to be maybe in a different piece of the pie, but doing it in our office. So having doses that haven't been shown efficacious for ketamine, right? And so our prescribers will say, no, that if you're here to treat this specific thing, we're going to look at the evidence and see what is the right choice there so that when things go wrong, which sometimes they do, even if you're trying your best to sort of inform safety, there's sort of a clear and reasonable path back so that both our patients and ourselves, and God forbid our lawyers or malpractice insurance providers or the underwriter, says, why did you do that? There's like an established pathway that's not just true for psychedelics, it's true for medicine in general. And I think that that's something that is worth looking at. It's something that's been a little bit of a wild west with ketamine because it's all off-label and there isn't really a great, huge, solid body of evidence. There's a lot of different ways you can look at it and shape it towards how you want it to be. And we've seen the industry do that already in some really cool, innovative ways that give access and in some really scary ways that cause harm.
And as a follow-up question, Greg, specifically with the outcomes, are there any specific patient-reported outcomes that you're looking at in terms of how does the treatment actually improve their symptoms? Is there any things that you're tracking there?
Yeah, so I'll be honest and say that I think there's a little bit of reluctance on our side to be using some of the more standardized survey metrics. And this is more on our practitioner side, feeling like they're not necessarily as relevant as they could be. And so in many ways, we are relying a little bit more on our homegrown systems in terms of receiving the feedback to the questions that we have developed and then providing ample opportunity for folks to give us both the kind of rate us on these scales, but also ample feedback for them to be giving us qualitative written feedback as well. As it relates to the patient-reported outcome side of this, I guess it's also really important for us to potentially name that, and this has been a learning for me stepping closer to the operation, it's really important for all of us to be centering what the patient's needs and desires are as it relates to their success in care. They get to define that, and they get to work with us one-on-one with our practitioners in measuring, are they making that progress? And that's an ongoing dialogue that's happening from one week to the next in their relationship with us.
Okay, great. And then Brooke, as a follow-up for you, with the ketamine and the evidence base, is there a particular route that you guys are offering at your clinic?
Yes, we only do intramuscular injections, and we use a very particular dosing. We only do on-site. We don't do anything remote, and we did that even all through COVID with a lot of COVID precautions in place. We never had an exposure on-site for us or our patients. So I think that our prescriber, if he was here, he would say that he has chosen intramuscular only because it is the least, it has the most evidence behind it as efficacious for the things we treat, which are PTSD, depression, anxiety, and OCD, and bipolar depression. And that there's the biggest body of evidence that can give a clear evidence-informed treatment plan with the least body intrusion. And so for the experience that people are having, and we approach, for ketamine work in particular, we'll see what happens with the other ones as they keep rolling out, but there's sort of like the biological component, and then there's the psychological component or the psychedelic experience and how those interplay. And so we wanted to provide something that we know is gonna maximize the biological potential for healing to what's being treated, while also allowing a little less intrusion on the physiological and psychosomatic impact of the psychedelic experience. And so IM hits that sweet spot where you're not having to be monitored and hooked up to an IV, but you can get a little bit more evidence-informed medicine at the right time and levels.
Okay, great. Now let's pivot on to talking about sort of the clinicians and the staff. Quality and safety are just really critical. They're only as good as the clinicians and staff who are trained. So can we talk a little bit about, one, how do you train your staff, given that this modality is sort of really not necessarily in medical schools or training programs per se? And then two, how do you incentivize them? What's the compensation and incentivized structure for them?
So I'll dive in as it relates to the training side. So we are a training site. And so we have a homegrown training program, and supporting the didactics, we also have a lot of built-in systems and processes for our folks to be learning together and from one another in this work. And so we have structures where we've got built-in supervision, we have built-in consults, depending on whether folks are licensed or unlicensed. We have, and supervision meetings are happening on a weekly basis. Consult meetings happening on a weekly basis. We have consult groups where folks can come in and discuss actual cases and learn from one another. We've got monthly community meetings where folks are coming in and bringing questions that are coming up, and they can all discuss as a group. We have weekly documentation support where our QA manager holds office hours and can support folks with their documentation questions. And then our clinical director is really maintaining a very strong finger on the pulse of how things are going. So she's really looking at client experience surveys, she's maintaining ongoing dialogue with our therapists, and then in doing so, identifying areas where there may be a need for additional training. So we're constantly calling folks in to offer additional didactic training throughout the course of the year as we see needs arising. As it relates to the incentive, I think that comes in a couple ways. One is our compensation structure. So our associates are paid on an hourly rate, and our associate structure, for those of you who may not know, a lot of times when folks are fresh out of school, the expectation in the behavioral health sector is that they're working for free in their hour to earn their hours towards licensure. We fundamentally disagree with that. We think that that is not an equitable way to bring people into this field, and so we are paying folks to be working with us in their time gaining their hours towards licensure. We would love to be paying them more, and so that's how they work. For our licensed folks, they actually work with us under a fee split model, and so that actually incentivizes them to be out working to bring additional folks in and to be diversifying their payer mix. But it is through the associates that we're paying at the lower rates that we are able to then assign more of our lower fee clients because that kind of works for the business in that way. I'll leave it at that and let you answer. We're running short of time.
Yeah, so we have two. We pay, everyone that works for us has a salary, and the salary is like about in the 80th percentile for comparable jobs. And so it's not the best paying job, but it's it's a good job if someone's looking for a job, a similar role in our community, doing similar types of things, with full benefits. So it's like a good doctor or therapist job with benefits, and all the standard stuff there. And then if there's profit left over at the end of the year, we have two places that we put it. Some of it gets divided up and put back into as a bonus for the clinicians, for everyone who works there. So we split part of it up and we divide it amongst us, and we're like, yay, we worked extra hard and we have extra money. So happy, merry holidays, or whatever you're celebrating. And the other half gets funneled and paired with a partnership we have with a 501c3 fiscal sponsor and a local community mental health clinic that treats mostly BIPOC, transitional age youth, but doesn't have psychedelic therapy. And so those people get granted, their patients come to us and they get granted. And so part of our profit and part of their philanthropy provides access to that part of our community that can't afford our service. So we do a little bit of a rob from the rich and give to the poor. And then we also have a fiscal partnership with someone who raises money from people that have wealth that want to share it. And so we provide access that way. And also our trainees and fellows get paid a going rate for whatever their job, so that we want people of all across our whole community to be able to come and say, I'm looking for a job as a psychiatrist and I'm interested in this specialty, and that they could also be interested in maternal health, or they could also be interested in adolescence, and that they can pick that this is positioned as a job for them that's like a specialty that's equal to any other specialty as far as job salary and benefits.
Excellent. Now, as we'll take questions from the audience, so feel free to put them in there. But as we wait for questions to come in, any parting thoughts that you guys want to share to funders who are looking at investing in sort of clinics? Brooke?
We talk a lot about sort of working across differences in psychology and how important it is to know what those differences are and to know how to navigate that. And I think that that's true for healthcare providers and for investors or business people. But we're working across a difference, and there's different languages. There's different values sometimes, and there's different understanding of what we mean, even if we're saying the same words. And to really remember that when those differences can be successfully navigated, that's when success is going to come. That if we erase the provider's language and look from a purely fiscal model, like how are we going to make our money back? How are we going to make ourselves the most important ketamine clinic or MDMA clinic in the world? That's going to last for a very short time. And in service of our patients, we need to make sure that we are creating systems of care that can last for a long time and really change the way that medicine is broken as best we can. So thinking about trying to learn how to work together despite having very different viewpoints, I think will be beneficial for all of us.
Thanks, Brooke. I would add on to those remarks that we're a nonprofit organization, so we do rely on philanthropy. And to be honest, I feel like there is this philosophy of philanthropy that, we heard from some folks earlier today that philanthropists are wanting to put money towards more catalytic things. And I think there is this philosophy that, folks want to see you moving more and more quickly to a self-sustaining model. And I'll be honest, in stepping in the operations role, I was starting to put that pressure on the team that we really needed to be moving more in the self-sustaining model. And as I've really peeled back the onion and really started to understand, it's likely we're going to be needing philanthropic support for the foreseeable future, because at the end of the day, we are so at the beginning of this, and the business models for this are still being figured out. And so if we want to be doing things like Alchemy is doing as it relates to enabling access in these early days, training diverse providers, there is a huge role for philanthropy to be playing there. And I want folks to understand that we need that capital, and we need that capital to be patient while we are maturing alongside of the maturation of the field.
Okay, excellent. So a few questions here from the audience. The first question for Brooke. Can you talk more about your LLC research side of your business?
Sure. That's kind of vague. We do MDMA research. We've done 4 MDMA clinical trials for PTSD. We do psilocybin research. We are working with psilocybin for depression right now, and we're about to start working with anxiety and LSD. And so, in the vein of being evidence informed, like this is a really great way to really understand what it is that you're going to be selling to the people in your community that are coming to you for treatment. And so it initially started that way, and sort of like, oh, we could, like, this will be a great way where we can learn how to do it, so when it's for sale, then we'll know how to do it. But it's also grown through that to be now like really looking deeply at what are we doing. And so having the research branch allows us to kind of have our toes in, like, what is happening here? And so it becomes less about like what we want to be happening or what our own values are, and more about science and medicine and psychology and practicing that. So that's why we have it, and it gives us a little diversity in our day's work as well.
And then another question is around, are there any thoughts about looking at group models to help increase access and lower costs? Right?
Yeah, we actually are doing some group work. Those can be a little trickier to operationalize. I mean, there's a lot of coordination that actually has to happen. So we've done, we're doing 3 in this fiscal year, and it certainly is a way for us to be increasing access, reducing costs, and I think, frankly, adding a new element to the healing process by allowing folks to be healing alongside of other folks that are having shared similar experiences. So it's more than just the cost. I think there's an added benefit from the actual outcomes side of things as well.
Healing happens in community, so if we can find ways to confirm that that's a valuable thing, it's just going to benefit everybody.
Yeah.
And then our last question, do we find that there's a specific market that their clients come from in both of the centers?
Our number one referral source is other providers in our community that don't do the work that we're doing, but work in psychiatry and psychology. And our second highest referral source is other patients. So word of mouth is where our marketing goes, and we like it that way.
Yeah, similarly. We're certainly serving a local community, and we are serving a very distinct population, right? We are targeting our services to BIPOC and queer populations, and we're a unique offering in that regard in our local community. And so that word of mouth is certainly getting out there. And we've got a pretty substantial waiting list for our services, and we're really lucky in that regard.
Great. Well, thank you both for joining us today, and thank you, audience, for being here.